The AHAB Activity Monitor is an OU-developed technology that has the potential to enrich the lives of millions of lower limb amputees around the world. This potential will be reached by offering prosthetists a more standardized and objective approach to assessing amputee activity levels. Amputee activity levels are a crucial part of the prosthetics industry because they dictate the amount of reimbursement an amputee receives for the purchase of their prosthetic device. The AHAB technology will ensure that prosthetists are able to assign more accurate activity levels, which will result in amputees receiving prosthetic devices that better fit their lifestyles. If OU can secure an additional $100,000 in grant funding for continued research and development and partner with a product developer in the prosthetics industry, this technology can earn OU between $500,000 and $600,000 within 10 years of commercialization, as well as help to improve the lives of over 50,000 lower limb amputees within just 5 years of commercialization. We are the technology development team. I'm Byron Dale, a senior petroleum engineering major from Tulsa, Oklahoma.
Carl Smutko, chemical engineering sophomore from Bartlesville, Oklahoma.
I'm Dylan Carroll, engineering physics senior from Columbus, Georgia.
And I'm Allie Browning. I'm a senior majoring in economics and geography, and I'm from Southlake, Texas.
As you guys heard, Sam Perrell was our team leader this semester. The inventor of our technology is Dr. Sesh Kamuri, and we had two mentors, Blake Gudgel and Jay Martin. Now let's take a closer look at an example of a common problem within the prosthetics industry. Susan Bailey was infected with E. coli bacteria in June 2007. The infection spread quickly, and in order to save her life, doctors were forced to amputate both of her legs. Amazingly, Susan survived and began the difficult road to recovery. However, she was met with an unexpected roadblock when her insurance provider only covered her for prosthetic limbs that are literally called stubbies. Stubbies do not bend at all. They make walking extremely difficult and even cause Susan to fall over often. Susan's a mother of two young, energetic boys. She needs to be able to pack their lunches, take them to school, and to soccer practice. Two separate appeals to her insurance provider in an attempt to be covered for higher functioning prosthetic devices called C-legs. C-legs actually bend at the knee, which makes walking a lot easier and less exhausting, but they cost $50,000 a limb. Both of Susan's appeals were denied. It was not until this story got national news coverage that Susan's insurance provider finally gave in and decided to cover her C-legs. Unfortunately, Susan's story is not unusual. There are millions of lower limb amputees that suffer from receiving prosthetic devices that don't best fit their lifestyle. This problem arises because prosthetists are being forced to underprescribe activity levels due to a fear of being audited. Amputee activity levels range from K0 to K4, with the most active amputees being rated K4. As I mentioned, these activity levels are important because they dictate how much the amputee is reimbursed for their device. A K3 amputee can receive, on average, $50,000 of reimbursement for their prosthetic device, which enables them to purchase a very high-functioning device. Whereas a K2 level amputee is reimbursed on average only $5,000 for their device, which restricts them to a much lower functioning device. The problem with this current system is that in many cases, insurance companies and prosthetists do not agree on amputee activity levels. So if the insurance company believes that an amputee is a K2 level, but the prosthetist rates them a K3 level, the insurance company will then perform an audit on that prosthetist to collect the difference in reimbursement. In a recent survey, 78% of prosthetics clinics say that audits have negatively affected their ability to fit their patients with better products. In most cases, these audits occur because there's a lack of objective data in distinguishing between K levels. 90% of all lower limb amputees are K3, K2, or fall in some gray area in between the two. And from speaking with many prosthetists, there's a general consensus that 50% of the entire lower limb amputee population falls within this gray area between K3 and K2, and deciding which level they actually are is completely a subjective decision. Audits are affecting the entire prosthetics industry. Last year alone, over 3/4 of all prosthetic clinics were audited. Of those audited, 90% chose to exhaust time and money in a lengthy appeals process. These audits resulted in $40 million of denied claims in the prosthetics industry last year alone. Carl's going to tell you how the AHAB technology bridges this disconnect between insurance companies and prosthetists in deciding amputee activity levels. Carl?
The AHAB system provides prosthetists with objective data about patient activity. While the system itself can deliver a K-level recommendation, more importantly, it provides prosthetists with useful information for them to deliver their own K-level recommendation. For example, the distance traveled by an amputee during the evaluation period, or the cadence variation, which prosthetists tell us is a main determining factor between K2 or K3 patients. This data is not only valuable during the initial K-level recommendation. If audited, prosthetists can provide this data as concrete evidence to their claims. Because they no longer have to fear the audit process, the rate of underprescription should decrease. This technology offers clear benefits to 3 parties. First, prosthetic clinics will save, on average, $18,000 per year by using the AHAB system. Insurance companies will receive this objective data to help better understand why prosthetists rate patients at the K levels they rate them at. This will decrease the costly audits that are costly not only to insurance companies, but also to clinics. Finally, patients, like Susan, will be rated at more accurate K levels and be able to receive the prosthetic limbs that best fit their active lifestyles. The AHAB system has been developed here at OU by Dr. Sesh Kamuri and his team. The AHAB hardware is a small device about the size of an iPhone that clips onto a patient's limb. 4 sensors lay within the socket of the patient and collect data over a 2-week evaluation period. After this evaluation period, prosthetists can upload the data from the hardware into the AHAB software. The underlying AHAB algorithm is what sets this technology apart from existing technologies. It transforms this raw force data into something prosthetists can actually understand and use. This algorithm also works for any patient, regardless of residual limb shape or prosthetic limb type. Now Dylan will tell you about the existing market for this technology.
Thank you, Carl. In order to benefit the maximum amount of amputees possible, the AHAB will be targeted towards prosthetic clinics. In particular, clinics that have the capacity to adopt advanced technology like the AHAB in order to defend themselves against insurance audits. Out of 3,200 prosthetic clinics in the United States, we're targeting 20% of that, or 640 clinics. Let me explain where we get that number from. The clinical market, while it's fairly large, is also very fragmented. One player, Hanger, makes up 23% of the entire clinical market. An additional 14% is made up of mid-sized networks of clinics. These are anywhere from 5 to 40 individual facilities that have banded together in order to cut costs and share technology. The remaining 63% is made up of small independent clinics. Many of these are literal mom-and-pop shops. So the 20% of the market that we'll be targeting are those mid-sized clinical networks, plus the top 6% of the small independent clinics. In particular, young, ambitious prosthetists looking to make a name for themselves as technological innovators. The total value of this market is $1.9 million per year. Now, we've chosen to focus on these mid-sized clinical networks because they lie in a sweet spot between the ability to adopt new technology and the need for audit protection. So, for example, Hanger, while they have a lot of resources to invest in new technology, they also don't really have need for a lot of audit protection. They have a lot of support staff that handles that for them on the back end. And the small independent clinics, while they're more affected by audits, they also don't have a lot of resources to invest in new technology. The mid-sized clinics, however, both have need of audit protection and they have the capacity to adopt technology like the AHAB in order to defend themselves against those audits. For these mid-sized clinical networks, the AHAB system is ideal. So now let's take a look at a couple competing activity monitors and we'll see how the AHAB compares. We have the IPEX lab from College Park Industries, targeted towards the research market. And we have Orthocare Innovations' Europa system. The Europa is similar in many respects to the AHAB with a few key differences. Both of the existing activity monitors have not succeeded in penetrating the clinical market. This is because they've failed to convince prosthetists of their value. This is key, as prosthetists are the ones actually using and buying the activity monitor devices. All 3 of the activity monitors record the forces on the prosthetic socket. However, the IPEX lab and the Europa lack the comprehensive, research-backed software analysis that the AHAB provides. This is key to get both insurance companies and prosthetists to agree on a functional level assessment of each patient. This is truly what sets the AHAB apart from the two competing activity monitors and what will ensure that it penetrates the clinical market. Finally, both existing activity monitors are fairly expensive. By using a recurring annual subscription model, the AHAB avoids the expensive upfront costs that prosthetists have told us really deter them from having invested in previous activity monitors. Now let's take a look at the existing value chain and see where the AHAB fits in. As it currently stands, prosthetic clinics fit their patients with prosthetic devices. The patients pay the insurance company, which reimburses the clinic. However, as Byron's already discussed, clinics are losing on average $20,000 a year in denied claims. Right, so OU solves this problem by licensing the AHAB technology to a product developer such as OrthoCare or Willowwood. Now, this licensing agreement is important in order to take advantage of the existing sales relationships of the product developer in such a small and close-knit community of developers in the prosthetics industry. The product developer will sell the AHAB system to the prosthetic clinics. The clinics will use this to test their patients and will send the data from those tests to the insurance company. This will avoid the costly audits. Now let's take a closer look at how the money will flow back to the University of Oklahoma. Each clinic will pay a recurring annual subscription fee of $600 per unit to the product developer. The cost of the hardware is subsidized in this subscription fee. The product developer pays a one-time manufacturing cost of $200 per unit, as well as a 5% recurring royalty rate back to the University of Oklahoma. This translates to $30 per unit per year for each of the years that the prosthetic clinics are using the AHAB software. With this arrangement, each of the key players benefits. Once the market is saturated, OU will see $80,000 of annual royalties per year, and the product developer will see $1.5 million of revenue per year. Finally, the prosthetic clinics will see a total savings of $8.6 million across the industry, as well as better care for the 50% of their patients that lie in between the K2 and K3 functional levels. I'm now going to hand it over to Allie, who will talk about what these numbers will look like in the AHAB's future.
Thank you, Dylan. Grant-funded research performed here at OU, as well as the subscription-based pricing model that Dylan discussed, will ensure the AHAB system's financial profitability. The research team is currently pursuing grant funding for a 3-year clinical research study. This research study will cost $100,000 per year for 3 years. It is key that grant funding is secured to cover these costs. Now, OU can begin to license the technology during the first year of this research, which will provide the development and design work necessary to commercialize the technology. The licensing arrangement will be profitable for both OU and the licensee. The licensee will incur an initial investment of $250,000. Then, at an annual recurring price of $600 per unit, we project that the licensee will break even in year 4 and reach a 15% market share in year 5. They will achieve this by leveraging their existing overhead, supply chains, and sales relationships. At this level of market share, the licensee would expect a $1.35 million in net profit after 5 years of sales, and OU, at an estimated royalty rate of 5% of revenues, would earn $170,000 over those 5 years. So the AHAB technology will be a profitable addition to the licensee's existing product portfolio while providing OU with a recurring revenue stream. Now let's look at the steps that still need to be taken in order to realize these benefits. Moving forward, the research team will continue to apply for funding. Dr. Kamuri and his team have already developed a grant proposal to apply for funding from sources such as the National Institute for Health, the National Science Foundation, and the Veterans Administration. At the same time, OU will explore intellectual property protection for the hardware and software system as a whole. Then, backed with funding, the research team will proceed with their 3-year clinical research study, during which time OU will approach potential licensees who will commercialize the product and bring it to market. This commercialization strategy benefits all of the key stakeholders in the industry. OU and the licensee will both benefit from a profitable licensing arrangement, while clinics will save money from expensive audits. But most importantly, the AHAB technology will immeasurably benefit thousands of amputees by securing them the prosthetic limbs that they need to live their lives to their full potential. Thank you so much for your attention tonight, and we'd like to extend a special thank you to our inventor and mentors, Dr. Kamuri, Jake, and Blay, whose insight and passion about the industry have been invaluable to us this semester. We'll now open the floors to any questions you have.